It's my pleasure to introduce Drew Ambrosi, who's going to be speaking with us this morning. He's visiting us from the Duke University Medical Center and the Duke Clinical Research Institute, and is going to be talking to us about emerging therapies in heart failure. Drew is a native of upstate New York. He did his undergraduate work at Georgetown and then Northwestern University for medical school, Stanford University for his medical residency, and is currently a fourth-year fellow at Duke, where he is completing his training in cardiology. Drew has a very impressive CV, which would make him probably appropriate for an associate professor at this point. He has more than 65 peer-reviewed publications, 25 of which are first author. And many of these are related to national and international heart failure studies. His collaborators have been really luminaries in the field of clinical heart failure, including Paul Heidenreich, Adrian Hernandez, Mihai Georgiade, Greg Fonarow, and his involvement with many studies that have both looked at introduction of new therapies as well as evaluation of the demographics and potential treatments of acute decompensated heart failure. So Drew is going to talk to us today, as I say, on emerging therapies in heart failure, and please welcome Drew for us.
All right, thank you so much for that introduction. I really appreciate it. So as Dr. Gibbons said, today I'm going to be talking about emerging therapies in heart failure. And this is a topic that's really near and dear to my heart. A lot of the trials I'm going to discuss today are things that I've worked on DCRI and also as a resident and a medical student. So here are my disclosures. So I'm funded by a T32 institutional training grant. I don't receive any additional outside compensation, but my research is supported by the NHLBI and industry, and I am going to be discussing some investigational uses of FDA-approved drugs today. So I have three main learning objectives. So first, we're going to review the expanding indications of angiotensin receptor neprilysin inhibitors in the management of heart failure. Second, we're going to talk about the clinical relevance of iron deficiency as a comorbidity and the role of intravenous iron supplementation. And finally, I'm going to give some insights and reflections on the state of site-based research in North America and in the larger world. So by way of introduction, so first I'm going to talk about Entresto, also known as sacubitril/valsartan. So this is a first-in-class angiotensin receptor neprilysin inhibitor. And what that means is, first, it's valsartan, which is covalently bonded to sacubitril. So valsartan is an ARB, an angiotensin receptor blocker, which blocks the renin-angiotensin-aldosterone system and prevents vasoconstriction and abnormal retention of sodium. Sacubitril, the other component, is a neprilysin inhibitor. And what neprilysin is it's an enzyme that, among other things, breaks down natriuretic peptides. So when you give a neprilysin inhibitor, you increase the circulating levels of natriuretic peptides, the good neurohormones, and you cause vasodilation and natriuresis. Now, a couple important things to know about this molecule. There's a reason it's covalently bonded to the other one. You can't give them separately. In animal studies, when you give sacubitril alone, it has a variety of substrates, and one of them is angiotensin 2. So you actually have no hemodynamic effects when given in isolation. They have to be given together. The second important thing for clinical practice is that if sacubitril is given with an ACE inhibitor, you have an increased risk of life-threatening angioedema. It's still in the single digits, but the risk is somewhat increased. And that's because the angiotensin converting enzyme inhibitor and neprilysin both break down bradykinins. So you can get dangerous levels of them. So before I talk about some of the trials I'm working on now, I think it's helpful to know what's already been done in this field. So most people are familiar with the Paradigm-HF trial. This is the largest trial that was ever conducted in heart failure. More than 8,000 patients were enrolled across the globe. So it enrolled patients greater than or 18 years of age with a history of chronic heart failure. Patients had to have an ejection fraction between 35 and 40%. And the reason there's a range is halfway through the trial, they amended the protocol and decreased the ejection fraction. It has nothing to do with the efficacy of the drug in patients with an EF between 35 and 40%. While the trial was being conducted, the Emphasis HF trial studying eplerenone was released, and the investigators were concerned that they weren't going to have enough events, so they wanted to decrease the ejection fraction to make sure that they were adequately powered and on track. Patients had to have symptoms. They had to have New York Heart Association class 2 to 4 symptoms. They also had to have an elevated BNP and an N-terminal proBNP. And finally, and importantly, patients were required to be on a stable dose of a beta blocker as well as an ACE inhibitor or an ARB. And this had to be equivalent to at least 10 milligrams of enalapril once daily. Here's the overall study design. In short, there were 2 sequential single-blind run-in periods followed by the randomization. So first, patients were started on enalapril and up-titrated to 10 milligrams twice daily. Patients who tolerated that then went on to the sacubitril/valsartan run-in phase, and they were up-titrated to 200 milligrams twice daily. In patients who tolerated both of those, subsequently underwent randomization and either received enalapril with the target dose of 10 milligrams twice daily or sacubitril/valsartan at a target dose of 200 milligrams twice daily. Patients were followed for about 27 months for a primary endpoint of cardiovascular mortality plus hospitalizations for heart failure. So enrollment occurred between 2009 and 2012. As I mentioned, there was a run-in phase, and there was about 10,500 patients in that. Ultimately, about 8,400 patients underwent randomization. So about 20% of patients didn't tolerate the drug and failed the run-in period. The mean age was about 64, which is pretty typical for a heart failure trial. 80% of participants were male. Ischemic etiology was present in 60% of patients. The mean EF was about 30%, so most patients had a severely reduced EF. And importantly, the majority of patients had New York Heart Association functional class 2 or 3 symptoms. So a large majority of patients had mild symptoms. Patients were also exceptionally well treated with background therapies. Beta blockers, 93%. By definition, you had to be on an ACE or an ARB to get in the trial, so 100% of patients were on that. And MRA, as in spironolactone and eplerenone, was present in about 60% of patients. So they're very well treated. For the MRAs, I mean, this is much higher than we see in real-world clinical practice when we look at guidelines or when we look at registries in the United States. And importantly, by the end of the trial, most patients had gotten to target dose. So patients were on about 375 milligrams of sacubitril/valsartan and 19 milligrams total daily of enalapril. All right, so here are the primary results of the trial. So I think this is very impressive. So as I mentioned, the primary endpoint was cardiovascular mortality plus hospitalizations for heart failure. And there was about a 5% absolute risk reduction, 26% versus 21%, when the sacubitril/valsartan group was compared to the enalapril group. In addition, each of the components of the primary composite were also statistically significant. Probably most importantly, one of the secondary outcomes was all-cause mortality, and there was an absolute risk reduction of about 3%, which equated to a relative risk reduction of about 15%. Take a minute to think about this. That's extremely impressive. That's sacubitril/valsartan versus the gold standard ACE inhibitor. There's lots of drugs that we talk about and that are, that are approved by the FDA and are incorporated into our guidelines that do not reduce all-cause mortality, that just have an effect on a composite of cardiovascular morbidity and mortality or major adverse cardiovascular events. When we had our investigator meeting for the Pioneer HF trial, Dr. Brunwald sat the whole room of 200 cardiologists down and asked them, how many drugs like that in your life do you know that decrease mortality, improve survival? It's very few, less than 10 drugs. So I think that these are very impressive results. And in addition, when you look at the exploratory outcomes, it also decreased all-cause hospitalizations, ER visits, as well as outpatient worsening heart failure. This last endpoint is an important one. As we begin to penalize hospitals for excessive 30-day readmissions, we're really changing practice patterns, and we're finding in a lot of clinical trials that patients aren't necessarily going to the ER or being hospitalized. They're being seen in clinic and getting IV diuretics or having their oral diuretics increased. So this actually accounted for about 20% of the events in the trial. So it's not just hospitalizations and death. It actually improved people in the outpatient setting as well. As far as safety goes, I think the data is equally impressive here. When you look at, depending on how you classify renal insufficiency and hyperkalemia, there tended to be less with sacubitril/valsartan compared to enalapril. There also tended to be less bradykinin-induced cough, which is a big thing with patients and can occur in more than 10% of patients and often limits our ability to start these medications and keep people on them. There was no difference between the group in angioedema. So really the main trade-off here came down to hypotension. So if you look on the far left-hand side, there was more hypotension with sacubitril/valsartan compared to enalapril. It's about 15% versus 10%. So that really is the main trade-off of being on this drug. When you add the neprilysin inhibitor, there is more vasodilation and hypotension. There have been a number of secondary analyses that have already looked at this, and although hypotension is, patients can complain of pre-syncopal type symptoms. It can bring them back to your office. When they looked at patients who experienced hypotension during the trial who did not, patients derived a similar benefit from sacubitril/valsartan versus enalapril, and it actually only led to study drug discontinuation in less than 1% of cases. So what does this actually mean? I think it means that hypotension is a nuisance and it's going to bring people back to your clinic and potentially limit your ability to titrate the drug, but I don't think you're doing your patients any harm if they experience these events. So as a result of these impressive results, the guidelines were recently changed in 2016. So sacubitril/valsartan now receives a class of recommendation 1, level of evidence B-R, which just means that there's only one study out there, as a first-line therapy to reduce cardiovascular morbidity and mortality. Furthermore, the writers of the guidelines give a similar level of recommendation to switching patients who are tolerating an ACE or an ARB to sacubitril/valsartan. So this is really something that we should be thinking about in all of our patients. And as I highlighted before, there's a class of recommendation 3, and you can do harm to your patients if you quickly switch them from sacubitril/valsartan, or from an ACE inhibitor to sacubitril/valsartan. You have to give a 36-hour washout period. However, despite FDA approval and an enthusiastic recommendation in the guidelines, the real-world use of sacubitril/valsartan remains limited compared to its potential scope. So this is based on some work done out of Duke, but based on FDA labeling, nearly 70% of patients who are hospitalized for heart failure would be eligible for ARNI therapy. However, only about 2.3% of patients were actually prescribed sacubitril/valsartan in the first 12 months following FDA approval. In addition, although cardiologists and the ACC, HA, and HFSA have given an enthusiastic recommendation, not all heart failure patients are managed by cardiologists, and in a lot of rural communities, it's a family practitioner or an internist who's going to be starting these medications and monitoring them. And the American Academy of Family Practice has not yet endorsed the guidelines, and they actually wrote a review in their main journal saying that there were concerns about the methodology of the Paradigm-HF trial and an insufficient evaluation of harm. Okay, so I think this may be due to several knowledge gaps that have been identified. So, there's limited experience with sacubitril/valsartan in several key groups. First, as I mentioned, patients had to have stable heart failure, so we don't know nearly as much about the drug in patients who are hospitalized for acute decompensated heart failure. About 40% of the patients in Paradigm-HF had no prior hospitalization for heart failure, and only 15% of patients experienced a hospitalization for heart failure during follow-up for the trial. Second, there's limited experience in patients with severe signs and symptoms of heart failure. Less than 1% of patients had New York Heart Association functional class 4 symptoms at baseline. So only 37 patients with class 4 symptoms were randomized to sacubitril/valsartan out of a trial of 8,400 patients. So clearly much more limited experience. In addition, by definition, for the eligibility criteria, patients with de novo heart failure or patients naive of conventional RAS inhibitors were excluded. So several key groups in which the drug's not been fully investigated. So that brings me to some of the work I've been doing at the DCRI. I think the Pioneer-HF trial has been designed to address several of these key knowledge gaps. So the objective of the Pioneer-HF trial is to assess the safety, tolerability, and efficacy of sacubitril/valsartan compared with enalapril in patients with heart failure with a reduced EF, stabilized during hospitalization for acute decompensated heart failure. So in contrast to the eligibility criteria for the Paradigm-HF trial, so this also includes patients who are greater than or equal to 18 years of age. Patients have to have an ejection fraction less than or equal to 40%. Importantly, though, all patients have to be hospitalized for a primary diagnosis of heart failure. So patients are eligible for enrollment no earlier than 24 hours and up to 10 days after admission. Patients are required to have an elevated BNP and an N-terminal pro or an N-terminal pro-BNP as objective evidence of heart failure. And since patients are being enrolled and randomized during hospitalization for acute decompensated heart failure, we had to have some kind of definition of stability for these patients. So what we decided on was that they had to have a systolic blood pressure greater than or equal to 100 millimeters of mercury for at least 6 hours. They had to be on stable doses of diuretics for the past 6 hours, off vasodilators for the past 6 hours, and off inotropes for the past 24 hours. This slide shows an overview of the design of the Pioneer HF trial. So we're in the process of publishing this now. So the trial is being conducted at 100 sites in the U.S. Our target enrollment is 900 patients. The study is 12 weeks in duration. We're randomizing patients, again, to sacubitril/valsartan versus enalapril. And there's 3 phases to the study. So there's the in-hospital initiation phase. Then the first 8 weeks of the study are a double-blind treatment phase where patients are either receiving double-blind sacubitril/valsartan or enalapril. And finally, the last 4 weeks of the study are an open-label phase where all participants are receiving sacubitril/valsartan. So this is a schematic depicting the in-hospital initiation phase. So basically patients are screened. At that point, their last dose of ACE inhibitor is held. And if you're randomized to the enalapril arm, then patients receive 3 doses of enalapril in-house and are monitored for 6 hours. However, if you're randomized to sacubitril/valsartan, we have to accomplish a 36-hour washout period. So we allow 12 hours since the last dose of ACE inhibitor before the first dose of study medication is given, and then the first 2 doses of study medication are placebo. And it's not until you actually receive the 3rd dose that you get the first active dose of study medication. And then afterwards, since that's the first active dose, patients need to be observed for at least 36 hours before they could go home. So I think that this is a good way to accomplish the washout period in a double-blind fashion. But this has been one of the difficulties of enrolling in the trial. As you might imagine, this could prolong hospitalization by upwards of 2 days. And when you look at the data in the U.S., there's been an emphasis on length of stay over the last 10 to 15 years, and really the median length of stay is about 2 to 3 days. So this is kind of one of the most common calls I receive from sites when they're screening and trying to enroll patients. So it is difficult. But I think that, the way I explain it to sites is that if you were going to start a new medication in somebody, you probably would observe them for a period of time. So I think the same thing applies here when they're participating in the study. They're not stable and ready to go home. They're being started on something new, and you need to document that they're tolerating it. So there's 3 levels of study medication, dose level 1, 2, and 3. So it's sacubitril/valsartan 50, 100, or 200 milligrams twice daily, and enalapril 2.5, 5, or 10 milligrams twice daily. And the way that we're going about titrating the medication is all based on an algorithm using blood pressure. So when patients are randomized, we look at whether their blood pressure is greater than or equal to 120 millimeters of mercury or less than that. And as time goes out, the blood pressure cutoff gets lower. And so we're hopeful that using this algorithm, this will give clinicians a useful way to determine whether a patient should be up-titrated or not. So the endpoints of the study. So the primary endpoint is N-terminal proBNP. So our secondary endpoints are going to be serum and urinary biomarkers of cardiac remodeling and fibrosis, myocardial stress, and tissue perfusion and injury. We also have some exploratory outcomes. We're going to be looking at clinical outcomes. We only have 900 patients, so we're going to be underpowered for that. That's why it's exploratory in nature. We're also looking at some patient-reported outcomes and medical resource utilization. And finally, and probably most importantly, we're going to be looking at safety endpoints: symptomatic hypotension, acute kidney injury, hyperkalemia, and angioedema. So, I think this is a really exciting trial, and it's been a great opportunity for me to get involved with my mentors, Dr. Hernandez and Velasquez, and help manage the trial. And I really do believe that that we're gonna glean some very helpful insights from these data. We have about 700 patients now, so we're slated to finish enrollment at the end of this year, and we're hoping to probably publish the results, sometime next year, hopefully by the first or second quarter. And so there's just a few points that I wanted to make about it. So the first thing I think is it includes a lot of underrepresented patient populations that we need to know more about these drugs in. Patients hospitalized for acute heart failure. All 900 patients are going to be hospitalized. Also patients with de novo heart failure, which, if you look at the registry data, that's about 20% of patients who are coming in for acute decompensated heart failure. So it's a big patient population. It's a lot of young non-ischemics. And we're also going to be looking at in patients who are naive of conventional RAS inhibitors. Everybody in Paradigm HF had to be on at least 10 milligrams of enalapril once daily. So we don't really know how patients who are not tolerating a dose like that, we don't know how they would do with the drug. So a lot of unique patient populations. There's also some important differences in the treatment arm. This is the first trial to use the lowest dose of sacubitril/valsartan, the 24-26 milligram tablet. In Paradigm HF, there were only 2 doses. It was, at that time, they were referring to them as the cumulative dose. It was either the 100 milligram or the 200 milligram dose twice daily. And the manufacturer actually created this third dose in response to that hypotension signal, so that patients who are naive of a conventional RAS inhibitor or were previously on a low dose can be started on something lower and more gradually up titrated. So I think that that's a really exciting feature of this trial to see if that hypotension signal persists in patients who are started on the lowest dose and maybe brought up more slowly. I think it's also significant that there's no run-in period. As I mentioned, about 20% of the patients in Paradigm HF actually dropped out between the sequential single-blind run-in phase and the double-blind treatment phase. So this is going to be a more real-world representation. So some of those safety signals like hypotension, AKI, hyperkalemia, we're going to have a better sense of what that's like in a real-world patient population. And finally, I think the open-label phase is going to be very interesting as well. In the Paradigm HF trial, patients were started first on enalapril, then on sacubitril/valsartan, and if they tolerated those, then they were randomized. So everybody went from sacubitril/valsartan to study drug. Whereas at the end of this trial, patients are going to be either on enalapril or sacubitril/valsartan and then brought over to open label. So we're going to have a much better sense of how that real-world transition from either conventional ACE inhibitor or sacubitril/valsartan to open label sacubitril/valsartan goes. I also think there's going to be a lot of great insights from the endpoints of this trial. So the primary endpoint is N-terminal proBNP, and that is a surrogate marker. And I think that if you didn't have a trial like Paradigm HF to stand behind, it would be difficult for you to conduct this kind of study. I look at N-terminal proBNP kind of like LDL. There are safe and effective ways to lower LDL that improve your outcomes. And same thing with N-terminal proBNP. They're safe and effective ways to bring it down. Most conventional medications, beta blockers, ACE inhibitors, spironolactone, those all bring down N-terminal proBNP. But there's certainly unsafe ways to do it as well. So if you didn't already have an outcome trial, I think it'd be difficult to use that endpoint. It is also challenging having a laboratory endpoint. In a trial, if you have a patient that's lost a follow-up or is unreliable with their follow-up, it's pretty easy to find out their vital status. Most countries have a national database where you can find that. But when you're using a lab endpoint, if a patient doesn't show up at week 4 or week 8 of the trial to get their N-terminal proBNP drawn, then you don't have that data. So that is something that we're confronting now, how to deal with missing this. I think we're going to learn a lot about the mechanism of the drug with the serum and urinary biomarkers. That's going to be very helpful to understand normal physiology and how pathophysiology is addressed by sacubitril/valsartan. And I think it's also going to be very helpful to look at some of these patient-reported outcomes. We know we have good information on hard clinical outcomes with sacubitril/valsartan, but we don't know much about how it impacts quality of life or functional status. And that's actually often more important to patients than living longer. A lot of heart failure patients, when I talk to them about this drug, they don't say, is it going to make me live longer? They say, is it going to make me feel better? So I think that Pioneer HF is going to address some of those domains better than prior studies. And then finally, I think the most important part of this study is really to establish the safety of sacubitril/valsartan in this high-risk patient population. It's going to be looking at the hypotension, the renal insufficiency, and the hyperkalemia in patients with acute decompensated heart failure to see whether that's a safe point in time to initiate an up-titrate study drug. So in summation, I think Pioneer HF will further the existing evidence basis and inform everyday clinical practice by evaluating the safety, tolerability, and efficacy of in-hospital initiation of ARNI therapy in acute heart failure. There's over 1 million hospitalizations for heart failure per year, and if you look at the data, this is often our primary point of contact with patients. So this is potentially a new drug that can be started in that setting. So I'm going to go ahead and shift gears a little bit and talk about the clinical relevance of iron deficiency as a comorbidity in heart failure and the therapeutic role of intravenous iron supplementation. So in addition to working on some phase 4 studies of sacubitril/valsartan, a big part of my fellowship at DCRI has been working on a pivotal study of IV iron. And I think that this is a very underappreciated topic, and hopefully people will enjoy this. So heart failure with iron deficiency. So the prevalence of iron deficiency in heart failure is about 40 to 50%. And that includes absolute iron deficiency, which is defined as a ferritin less than 100, as well as relative iron deficiency, which is a ferritin between 100 and 300, and a transferrin saturation less than 20%. Importantly, it's present in patients with and without anemia. You do not need to be anemic to be iron deficient. And it's associated with worse quality of life, impaired functional status, and higher rates of cardiovascular morbidity and mortality, irrespective of anemia status. So I think this is a great figure right here. This really illustrates the fact that as patients become more symptomatic, as their New York Heart Association functional class worsens, the prevalence of iron deficiency goes up. And I also want to point out that these are patients with iron deficiency and no anemia. These are patients with iron deficiency and anemia. If you look at it, of the 60% of patients with class 3 or class 4 symptoms who have iron deficiency, the majority of them are not anemic. So if you're just looking for patients with a low hemoglobin or a low MCV or a low RDW, you're going to be missing a lot of iron deficiency. This is a comorbidity that's important and clinically relevant, independent of anemia. So why do patients with heart failure become iron deficient? Well, the answer is probably multifactorial. So in normal physiology, iron is absorbed in the small bowel and it's stored in the liver in the reticuloendothelial system, and from there it's mobilized throughout the body, including to the bone marrow where it's involved in erythropoiesis. So there's probably a few mechanisms. First of all, there's probably decreased iron absorption. A lot of these patients have gut edema. They have right-sided symptoms and they may not be absorbing iron as well. And they also have decreased intake of iron in their diet if they're sick and not feeling well. There's also probably some iron loss, most commonly from bleeding. About 40% of patients with heart failure have atrial fibrillation, so a lot of these patients are on oral anticoagulation, and about 60% of patients have an ischemic etiology, so there's going to be a lot of antiplatelet therapies out there. And then finally, there's probably decreased iron bioavailability. We're just starting to understand this, but heart failure is a very inflammatory state, and patients have high levels of interferon gamma and TNF alpha. And one of the acute phase reactants is a molecule called hepcidin, which actually blocks the absorption of iron as well as decreases its bioavailability in the circulating levels that are released from the reticuloendothelial system. And I actually think that this is probably the most important mechanism for why patients have iron deficiency. So what does it matter? Why does iron deficiency translate into all these bad things? I think everybody appreciates that iron is an important cofactor of hemoglobin, so iron it's relevant to the transport of oxygen around the body. But iron is also an important cofactor in a number of enzymes and structural proteins throughout the body. A number of mitochondrial proteins use it, as well as the electron transport chain. So it's really not just about oxygen transport, it's about oxygen utilization. It really affects every part of the Fick equation. And so if you look at what iron does, it causes dysfunction at the cellular level, decreased energy production and apoptosis. Iron deficiency causes tissue remodeling and adverse remodeling of the heart. And then at the individual level, that translates to some of the things I discussed before. So it reduces quality of life, as assessed by the KCCQ and the EQ5D. It impairs functional status pretty much by any means of measuring it. It increases heart failure hospitalizations, and it also decreases survival. And all of these things are independent of anemia. All these bad things happen whether you're anemic or not. It's much more closely related to iron deficiency. So I'm going to go ahead and talk about a few trials that have been done in this space previously and some of the trials that I'm working on. So I'm going to discuss these somewhat out of chronological order, but I think it makes sense to discuss oral iron before going into IV iron. So the Iron Out HF trial was conducted by the NHLBI-sponsored Heart Failure Network and sought to clarify the role of oral iron supplementation in heart failure. So 225 patients with stable New York Heart Association functional class 2 to 4 symptoms, and EF less than or equal to 40%, and iron deficiency were enrolled. It was a wide range of hemoglobins, all through the normal range, only excluding patients with dangerously low or dangerously high hemoglobins. And finally, patients had to be able to perform a cycle or treadmill exercise test and get an RER ratio of at least 1.0. And the reason for this is, as you'll see on the next slide, the primary endpoint is the CPET endpoint. So patients had to be willing to go through CPX testing. So patients were evaluated at baseline. They had their baseline CPET to see if they were eligible for the study. They were then randomized 1-to-1 in a double-blind fashion that was also stratified by site as well as by hemoglobin level to oral iron polysaccharide 150 milligrams twice daily or oral placebo. Patients were then seen at week 8 and week 16 was the closeout of the study. And the endpoints were functional outcomes, including CPETs and 6-minute walk, quality of life, as well as biomarkers. So here are the primary results. So on the left, we have the iron out HF trial, and on the right, we have FAIR-HF. And you can see both the ferritin and the transferrin saturation. So despite 16 weeks of high-dose oral iron supplementation, there was really minimal change in ferritin between patients receiving iron and patients receiving placebo. You can see here, this is the normal range. Nobody was moving into the normal range. In addition, the same was seen with transferrin saturation, minimal difference between iron and placebo. This was statistically significant, but not really a clinically relevant finding. So contrast this with the study I'm going to talk about next. FAIR-HF was the first large study of IV iron. So after a single dose of IV iron, you can see that ferritin normalized in virtually all patients. Same thing with transferrin saturation. So I think what's notable here is, patients, this is a single dose of IV iron. This is a high-dose oral day every day for 16 weeks. If you add this all up, this is about 20 times more iron than a single dose of IV iron. So it shows that oral iron does not work in heart failure patients. They don't absorb it. And a lot of research is being done right now to see why that's the case. People initially thought it was due to right-sided symptoms and gut edema. It doesn't seem to be the case. Most patients enrolled in this trial did not have an elevated JVP or things like that. But what correlated best with the poor iron absorption was the hepcidin level. It really seems that that it's the inflammatory state and this regulatory pathway gone awry that leads to iron deficiency in these patients. So as I mentioned, the primary endpoint of the trial was CPET testing. So you can see we have the absolute VO2 as well as the relative peak VO2. And as you can imagine, if patients' iron stores were unimproved after 16 weeks, there was no difference in their peak functional capacity. And the same thing was true for every other endpoint of the trial: 6-minute walk, quality of life, as well as biomarkers. There were no signals that oral iron was efficacious here. So in conclusion, high-dose oral iron minimally repleted iron stores and did not improve peak VO2 in patients with iron deficiency and heart failure with a reduced EF. These results did not support the use of oral iron supplementations in patients with HFrEF. So now I'm going to talk about some IV iron studies. So a lot of the attendings in the room, some of the more senior attendings, may remember a time when people really feared giving iron. It had to be given very slowly, and there were a lot of transfusion reactions. Well, that's not the case anymore. There's a number of new formulations. One of the most popular ones is IV ferric carboxymaltose. This is already FDA approved for patients with end-stage renal disease in iron deficiency anemia, as well as patients with iron deficiency anemia who are refractory to oral iron. And it's an efficient, high-dose way of repleting iron. Compared to earlier formulations, it's more stable and it has no reactions with dextran antibodies. So there's actually minimal risk of hypersensitivity or anaphylaxis seen with earlier preparations. It's safe and can be given in the office. Typically, it's given either as continuous infusion or a slow IV push over 10 minutes. In a meta-analysis of patients with IV iron and patients receiving IV iron, they looked at this compared to other IV iron formulations as well as oral iron, and really there was no increased risk of infections, no increased risk of infusion reactions, and there were less gastrointestinal adverse effects, which is a big problem with patients on oral iron. Patients don't tolerate it well. Not only does it not replete your stores, but it has some undesirable side effects. So as I mentioned before, the FAIR-HF trial was really the first study to look at IV iron. So it enrolled about 400 patients, all of whom had heart failure with a reduced ejection fraction in class 2 to class 4 symptoms, as well as comorbid iron deficiency. And it randomized them either to a single dose of IV FCM or matching placebo. And the results were quite impressive. So their primary endpoints were patient global assessment, as well as New York Heart Association functional class. And both of these improved, very, very quickly after administration. So this is the hazard ratio of a modest improvement, or the hazard ratio of an improvement of 1 New York Heart Association functional class. So when you compare IV FCM to placebo, it was superior, and you could see that there was differences in quality of life and symptoms as early as 4 weeks. So very, very soon after a dose. And when they went back and looked at their data to see if it differed between patients who were anemic and not anemic, the benefit was the same. It was not modified by anemia at all. So the next big study that was done was the CONFIRM-HF trial. This was done by a similar group. Most of these studies are based out of Europe, where IV-FCM is actually used fairly commonly in heart failure. And their primary endpoint was a 6-minute walk test. So again, similar inclusion criteria, a single dose, and then they reassess 6-minute walk at various points in time. And you can see that the curves begin to separate almost immediately, and it becomes statistically significant in about 24 weeks. And there's a sustained effect all the way out to a year. And the difference was about 30 meters in the 6-minute walk. So people might say, well, what does this mean? I mean, give me some clinical relevance for that. And so I don't know if there are EPs in the room, but what I've commonly heard people say is that this is comparable to what was seen in some of the trials of biventricular pacemakers or cardiac resynchronization therapy. So we're talking about a single dose of an IV drug comparable to a device that is expensive to place and is continuously in patients. So it's a pretty big effect for patients. In addition, although underpowered for this, they did notice that there was a reduction in heart failure hospitalizations. You can see the hazard ratio was pretty impressive, but very small numbers, so the confidence interval is actually quite wide for this. But some meta-analyses have been done of IV-FCM studies and have shown similar results on cardiovascular outcomes. So all the FCM patients were pooled together, all the placebo patients were pooled together, and it appeared to reduce heart failure hospitalizations. Some of these composites of heart failure hospitalization, cardiovascular death, or all-cause death, the only ones that didn't affect was cardiovascular death alone or all-cause death. But that's really just because we're dealing with very small numbers here. If you look at the hazard ratios tend to suggest benefits and have very, very large confidence intervals. So it's really just that, well, we're doing an ongoing study, so we're going to find this out for sure or not. But the thought is that these are just small numbers, and we just haven't been powered to look at some of these effects. But as a result of these data, the guidelines were recently changed for heart failure. So they now say in patients with New York Heart Association Class 2 and 3 heart failure and iron deficiency, replacement might be reasonable to improve functional status and quality of life. And that's based on some of the data that I just showed. And they give a class of recommendation 2B and a level of evidence B-R. I mean, however, how many people in the room actually change their practice in response to Class 2B indications? I think this is good, this is encouraging, and it's some great preliminary data, but we really need to go further and address some of the harder clinical outcomes here. So there's still some key unanswered questions. So one, we don't know the effect on clinical outcomes. We don't have any long-term data. We have data on a single dose of IV-FCM and patients followed up to about a year. But what's the effect of repeat dosing on patients? We don't know. And so the safety and efficacy of repeat dosing. I mean, how often do patients need to be redosed? Is a single dose enough? Or is this not a durable effect? Do iron stores go back to the deficient level again shortly thereafter? We don't know the answer to that. And we also need some data from North America. All the studies I previously showed were conducted in Europe. And we know from heart failure trials that there are tremendous geographic variation in patient characteristics, background therapies, and event rates. So that brings me to the trial that I'm working on, so the HeartFit trial. So the objective here is to evaluate the efficacy, safety, and tolerability of IV-FCM compared to matching placebo in symptomatic HFrEF patients with iron deficiency. So we're including patients who are greater than or equal to 18 years of age. They have to be symptomatic. Hemoglobin levels can be pretty broad. They have to have iron deficiency, either absolute or relative. We have an enrichment criteria, hospitalization for heart failure, an elevated BNP and intramural proBNP. And part of our endpoint, 6-minute walk, so that's required. Of note, if patients have a dangerously low ferritin, we do require a GI evaluation. And although oral iron is not effective, we want clean data, so we really are asking that patients not be on oral iron. If they're on a multivitamin that contains it, that's okay as long as it's less than a certain amount. So here's the basic design of the study. So it's in its infancy right now, but the goal is to have 200 sites in North America and potentially other regions across the world for a planned enrollment of 3,000 patients. It's a very pragmatic study. There's not very many contacts with the patients. After you enroll them, you give them their first dose. It's 2 doses of FCM on day 0 as well as day 7, 750 milligrams, or matching placebo. And then patients are seen back in clinic every 6 months, and their CBC and their iron studies are reassessed, and if they continue to remain iron deficient, they would receive another dose. If they're not iron deficient, they would roll over and receive placebo to make sure they're not getting too much. So that actually creates one of the challenges of this trial, maintaining the blinding. So logistically it's somewhat cumbersome because it requires both unblinded and blinded staff to conduct the study. But so far we have a number of sites that are up that are doing this just fine. And And so basically, patients will be seen back every 6 months. And then the primary endpoint here is going to be a hierarchical composite at 12 months. So this is a novel endpoint, and it recognizes that all these things are not all weighted equal. So first we're going to look at death. After death, if a patient hasn't had a death, they'd go down and look at hospitalization for heart failure. And these are both at 12 months. And then if neither of these events have occurred, the statisticians will look at change in 6-minute walk test at 6 months. So I hope people take away that iron deficiency is highly prevalent in HFrEF and is associated with increased risk of cardiovascular morbidity and mortality. And I really think that this is probably one of the most exciting trials going on in heart failure right now. We're going to really clarify the role of prospective treatment with IVFCM in addition to usual care among ambulatory patients with HFrEF and iron deficiency. So that brings me to my last learning objective. So we're actually running out of time, so I'll go through this one quickly, but I just wanted to talk some kind of about the state of site-based research in North America and some of my reflections on working on these trials at DCRI. So these are some data from a trial I worked on when I was a medical student at Northwestern. The Everest trial is one of the pivotal trials in heart failure. Over 4,000 patients randomized to tolvaptan, which is not used or standard of care. But the important thing here is that we actually went and looked at the data to see how sites were performing. So there were 436 sites participating in the Everest trial, and I think it's shocking, but we found that 20% of sites did not enroll a single patient. We then went on to look. I know not many people have published data like this because nobody wants to brag about this, but I had a mentor who was willing to admit his own shortcomings and look to see if things could be done better. So we then went and looked at sites and classified them as low, medium, or high enrollers based on less than 10 patients, 11 to 30 patients, or more than 30 patients. And bear in mind that the average follow-up in Everest was about 3 years, so people had a long time to enroll these patients. And we found that 60% of sites enrolled less than 10 patients, and that accounted for about 25% of patients. Contrast that with 10% of sites were high enrollers and enrolled more than 30 patients, and they accounted for 30% of patients. So there really is a lot of efficiency. A lot of sites are not enrolling any patients, a lot of sites are enrolling very few patients, and there's a small minority of sites that are really high performers. And there's a geographic component to this, as you might imagine. So North America and Western Europe, this tends to be where the low enrollers clustered, whereas South America and Eastern Europe tended to do much better and have many of the high-performing sites. So there is a geographic component here, and this has important implications for trials because, as I mentioned, there's differences in clinical characteristics, background rates, and event rates, so it can really affect how you plan your trial, what your sample size calculation is, what the patient characteristics are like at the end, and even the outcome of the study could be impacted if there's a regional signal. And it also seemed to be related to protocol completion. The sites that were enrolling a lot of patients, they did pretty well. About 70% of the patients enrolled there actually completed the protocol, compared to these high enrolling sites when it was about a coin flip, whether patients were going to stay on study drug and complete all follow-up assessments. And this is true of all trials in heart failure. So this is a number of recent trials, and really with the exception of ASCEND-HF, enrollment in North America has not been great, and this is kind of where we're settling out in heart failure trials right now. We're often enrolling less than 10% of patients, even though a lot of the companies that are developing these drugs are based in the U.S. and looking to enter the U.S. market. So, it'd be great if I could tell you that I had a simple solution to this. I really don't. But I do have some thoughts on, based on my work at DCRI on things that we could perhaps do better. So I think there are a number of barriers and some potential solutions. The first problem, I think, is that we really don't market ourselves very well in cardiovascular medicine. The prognosis of patients with heart failure is worse than a lot of cancers, but it just doesn't evoke the same visceral response in people. They don't realize it. So I think one thing we can do is really to improve awareness, to let patients know. I mean, in the Paradigm-HF trial, those patients had mild symptoms, but about 25% of them died or were hospitalized over a follow-up of 3 years. I mean, this is a serious thing, and there's drugs out there that can help them. I think another barrier is finding sites that are able to enroll patients, as I showed from the Everest trial. And really, a pretrial registry probably has a big role here. My mentor in medical school always advocated for this. Before you have them do anything related to a protocol, see if they can just identify the patients. If they don't, you've invested a little bit of money up front, and then you can close the site and go to a site that has more promise and potential to enroll. A lot of the study protocols are pretty time-consuming and do not really reflect the day-to-day realities of patient care. There really is an emphasis on moving from these complex protocols to more pragmatic trials, collecting real-world evidence. It doesn't make it as clean of an experiment, but it really gives you a better sense of, maybe not efficacy, but effectiveness of a drug. It has the potential to increase enrollment and improve participation. I also think we can improve the infrastructure for clinical trials and develop clinical trial networks. A lot of these sites, they trial ends, everybody's fired, they don't have the study coordinators anymore, and then they get approached by another site, and then they're hiring more study coordinators. A lot of wasted time and startup costs. For some of the trials I'm working on now, that you find that you activate them and you find that they don't have a study coordinator, that they don't have lab services on site to verify whether patients can be enrolled. It's really a problem. If we invested some money and had a pipeline of sites, I think that it would go a lot further. I also think we need to collaborate with other specialties. Everybody here probably thinks that a heart failure specialist or a cardiologist sees every heart failure patient. That's not true. In the community, a lot of these patients are taken care of by family practitioners, by internists. If you're talking about an acute heart failure trial, most of these patients are taken care of by a hospitalist or seen by an ER provider. So we really need to engage our colleagues and to do research more effectively. And we need to provide some incentive. At a place like Duke or the University of Washington, there is not as much incentive to participate in a clinical trial and enroll patients. You're not necessarily going to get your name on a publication and increase your academic portfolio. A lot of places don't have any way of compensating, so you're kind of doing it out of the goodness of your heart. So, really the secret out there is that from the early days of clinical trials of Caliph and Topol and IV lytics to the present, trials have really moved from academic centers to private practice. And the trials I'm working on now, more than 90% of the sites are private practice because they have the incentives aligned. They know their patients, they own the practice, they see the proceeds from participating in the trial, and it's financially viable and it's more of a priority. For a lot of the studies I'm working on, if I approach an academic site about being a center, there's no interest. People telling me they don't have time and then they don't want to be involved. So it really is a challenge. And then finally, I think we could do more to support sites. We have site activation visits and we get sites going, but we don't necessarily check up on them on an ongoing basis. I'm getting a lot of calls from sites, once a problem has occurred, once somebody is on blinded study medication, they've received open label ACE inhibitor and they're concerned about the risk of angioedema. We're not talking about things and working out all the kinks up front. So at this point, I'm pretty much out of time, and that's everything I had. Thank you so much for coming.
We have time for questions.
10 minutes.
Could I ask one first?
Yeah.
I was wondering if you could elaborate on what you consider to be the value of measuring N-terminal proBNP and what perhaps might be the fundamental mechanism of action of the ARNIs in terms of vasodilation versus some other end organ effect.
Yeah, I think that's a good question. I mean, that's one of the things that we're trying to determine from the Pioneer HF trial, exactly what the mechanism is. It does seem to be highly correlated to the changes in N-terminal proBNP. If you look at the data from Paradigm HF after the first 30 days at month 1, there was a profound difference in N-terminal proBNP, and how much of a decrease people had was related to what their outcomes and the efficacy of the drug was. And they further sort of defined what kind of events are occurring. And it seems like most of the deaths in the Paradigm HF trial were really driven by progressive pump failure or sudden cardiac death. So I think that it probably is a component of vasodilation and natriuresis that leads to remodeling of the heart, and it impacts those outcomes. But as far as more specific pathophysiologic mechanisms, I think we need to do more. And Novartis they've been good about sponsoring a lot of phase 4 studies, and there are a lot of ongoing studies looking at biomarkers, echo parameters. So I think that we are going to have a much better sense. One of the reasons we don't know much about the mechanism of the drug here is that, unlike most trials, this actually went directly from phase 1 to phase 3. There was no phase 2 study here. There was a prior compound, omopatrolit, which is a combination of ACE inhibitor and sacubitril, that was part of a large phase 3 study that was ultimately terminated because of the angioedema risk, but they felt like they knew enough about sacubitril and the mechanism that they were safe going forward and directly to phase 3. So we really did get clinical outcomes here before we got more basic mechanism. Other questions?
Okay.
Just a
comment. Really nice talk. I'd just like to make a comment about data coming from other countries. There is an outstanding example from the heart failure studies, TopCat, in which the patients from Russia and I forget what the name of it.
Republic of Georgia.
Yeah, they enrolled an entirely different population than the rest of the trial. Very clear. So I've been involved in about 25 or 30 studies over the last 25 years from PHRI. I can't speak to any other collaboration, but we've made an extensive study of the data coming from other countries. And this is a collaboration where there are as many as 80 countries. The biggest study that I know of is Interheart, which had 50. The quality of the data and the consistency of the data across countries is very uniform and really outstanding. Now, the one comment that if people want to drill down on this a little bit more, there was a wonderful article in the New England Journal probably less than a year ago by Salim and Janet Wittes, which showed that the variance that you get from a country is directly related to the number of patients that they enroll. And so, if you, are there going to be differences? In HOPE, for instance, which had an enormous p-value, there was no difference between the two groups in the U.S. And it almost stalled the acceptance of Ramaphosa by the FDA. So, message, relatively uniform and high quality data across countries. There are some outstanding examples, so we need to watch those with care.
Yeah, I mean the TopCat is a great example, and I think that the misconception is that they just realized that there was a regional effect kind of at the end of the trial. But now I've heard Bernie Gersh, who was the chair of the DSMB, talk about that trial, and really they recognized that there was a signal kind of all along, and they were alerting the investigators, and I think that it somewhat took people by surprise. They didn't recognize.
We went to the implicated places and checked it during the trial. And nothing came up on examination of the records there. That's all I can say.
And HFpEF is a challenging scenario. It's a little bit it's more difficult than in HFrEF. I mean, you have a low EF. I mean, that's an objective thing. It's not quite as subjective. And in HFpEF, one of the things that they've struggled with in trials is how do you make the diagnosis? And I think learning from the TopCat experience and the ongoing trials in HFpEF, they're making more of an effort to really verify the diagnosis. So in one of two ways. So one, they're requiring either an elevated BNP or an end-terminal proBNP, or two, they're requiring some sort of echo parameter, most commonly left atrial volume index, to really have objective evidence that this patient does indeed have HFpEF. This is not just a patient who's overweight and has a number of comorbidities that feels short of breath. Dr. Marr?
Drew, very nice talk.
Thank you.
I think part of the challenge is the inherent tension between study sponsors and their impetus to protect the drug and expand its indication and show safety and efficacy, and the real world application of the drug. We take life, for example. Out of 100 patients screened, probably 10 are enrolled. There's a lot we could learn from the 90 that have advanced heart failure and didn't make it into the trial. That probably would be more informative than the very selected 10 that end up in the trial. I wonder what your thoughts are on that.
I think that's a great point. Dr. Marr's giving me a hard time because I'm also the medical monitor for the LIFE trial, and we've corresponded via email and phone a number of times about the challenges. But he's, just so everyone knows, he's been one of our best enrollers. So although it took 100 patients, he did find the 10 needles in the haystack. I think that you're right. I mean, think there are a lot of patients we miss, and one of the things I suggested was a pretrial registry, but I think a registry concurrent with the trial also does have a lot of value. And we did discuss that at the Heart Failure Network Steering Committee, whether we should have a LIFE registry. And the challenge there was we were concerned that if we started paying sites to enroll patients in a registry that was really easy, that suddenly that would detract away from enrolling patients in a trial that's a challenge. So there is some balance. It's a good question.
Yep. Kevin?
Thanks, that was very nice.
Thank you.
Question about, you've thought a lot about sacubitril, clinical implications of what kind of cost
It is, yeah, it is quite expensive. It depends on what your insurer is, but the wholesale price would probably be on the order of about $4,000 a year, and so that is quite expensive. But there have been at least 4 or 5 cost-effective analysis, looking at the price in terms of quality-adjusted life years, and the bar that people commonly throw around is less than $50,000, and it does come in less than that. So you're right, it is expensive, but I do think that the expense is somewhat that it matches the benefit. And to give you a sense of how they came up with the price, it was based on the NOACs. Sacubitril/valsartan was priced to be sort of competitive with what apixaban and rivaroxaban and those drugs were when they first came to market. I think the reason those probably got quicker uptake than sacubitril/valsartan is people don't want to go and get their INR checked. There was a big convenience factor to the patient kind of up front when you start those medications. Whereas the sacubitril/valsartan, you have to tell your patient you're feeling well now, you think you're doing well, but you have a serious condition and the prognosis is not great. So it is more challenging to make that. But you're right, cost is a consideration.
Well, it's interesting you mentioned